Tamika, we haven't done anything yet. We haven't done anything. We've barely given just a whiff of drugs. What happens with an increase in resistance, increased work of breathing, and this is in a patient who's breathing on their own, not breathing through a PVC pipe. Okay. Again, we haven't done much yet. We're going to finish up here in the next couple of things. Pre-induction, we've already talked about this. We put them on high flow oxygen. We start to give them some of these medications. Some of these you know the impact of. This is absolutely vital. I want to be sure that I make it very, 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 very clear. I am not in any way, shape, or form advocating that you go into the perioperative arena and tell your clinicians that you were taught at VCU pre-oxygenation and denitrogenation is bad because it causes serious atelectasis. We can't do that. Wrong. What do you know about folks who are new laryngoscopists versus experienced laryngoscopists? You need more time. I'm advocating a really long pre-oxygenation. Buy yourself some time. You're filling up the reserve. You're filling up the tank. You're lengthening the time from apnea to desaturation. So I'm not advocating that. I'm simply saying we have to recognize that everything we do has a cost. And the cost of pre-oxygenation, it buys them an airway, buys you more time to not be in a hurry, but it also has a cost for the patient. Okay, then what do we do about that? We must implement strategies, particularly, is the patients under the care of new sRNAs different than the patients who are under the care of an experienced? We've done a lot of things. Maybe we paralyze them more fully. Maybe we denitrogenate and pre-oxygenate them more fully. That simply puts a bigger onus on us. So that's why I stress so much the idea that we really need to be undoing atelectasis to the extent that we can. How do we undo that? We'll talk about that with ventilatory strategies. You get something, but you've got to give something too to offset that as well. I'm not recommending you do this. I'm also not recommending that you extubate your patients on room air to room air. Studies will tell us that that will decrease the risk of atelectasis, but it's not necessarily safe practice. So we're going to talk about some of these things, especially under ventilatory strategies, but it's not to advocate, and I cannot be more clear about that. Don't want you to tell anybody that I told you not to pre-oxygenate or to shorten your pre-oxygenation time, not do it, or any of those things. Anybody have any questions on that? Okay. All right. But we also know, again, there are other costs. High flow gas, it's cold. If you want to drop your patient's temperature really fast in the perioperative period, keep their fresh gas flows at 5 to 6 to 7 to 8 liters. If you forget to do that for a period of time, not only is your vaporizer empty with no alarm on it, you also have a cold patient. So we know that this has an effect. We can imagine a drying effect. Patients who have very reactive airways, simply by putting the mask on their face, they'll start coughing. It's that high flow gas. It has a drying effect. It's very, very immediate, and it also can impact your cilia and their ability to function properly. That's a very bad thing. We want them all moving, little hairs to be moving it all up and out. Face mask, of course, adds dead space. That's space in the circuit that is not participating in ventilation. This is all pre-induction. And again, just kind of marching out. You guys are familiar with some of these things. You may have mentioned some of these effects of these drugs as you went through them. Did you talk about any of these effects when you talked about narcotics? We've talked about narcotics so far. So you've mentioned these things. Again, I'm just trying to inject this into the clinical arena and what this looks like when we get into the perioperative period. This is something folks forget about. Lidocaine blunts. Wake up a patient who you've just given IV lidocaine to because they were coughing, or you used an LTA. Anybody know what an LTA is? An LTA is a packaged carp eject. It has the carp eject in the back end, usually has 3 to 4 cc's of 4% lidocaine, and then it's attached to a big stick that's malleable, and it's got these little jets that spray out in all the directions. After there's a black line about halfway up it, and it's intended that you sink it down to where the black line is about the level of the vocal cords, and then you spray it, and in the subglottic area, I stress that because I've gotten myself into big trouble on that, it will spray 4% lidocaine throughout the airway to prevent a person from coughing on the endotracheal tube, the tube from bumping around on the carina and making them reactive, etc. Great for cases when you don't want to paralyze them, but you don't want them bucking on the tube. So it has a lot of great things. But when we use those, you wake a patient up who you didn't get the black line below the vocal cords, and they have a little bit of lidocaine up on their vocal cords, they cannot protect their airway. So don't forget, IV lidocaine works just as well. LTAs, if you put lidocaine down the endotracheal tube, that works as well. It will blunt their ability to protect their airway. So we've now put a patient who is not an aspiration risk at risk. All right. Some of the other events that take place in the induction period, these are more intuitive. We know that muscle relaxants have an impact on pulmonary function. Namely, they can no longer control their own respirations. They have no control over their pulmonary muscles. So that's an impact for sure. I spend a little less time on these because I think these are things that are much more intuitive. Induction of anesthesia, with or without muscle relaxation, further reduces the FRC and also impacts your closing capacity. So we have increased reasons that we see small airway closure. This is just a graphic. I think it's important to think about paralysis, all of these things. Initial upright position, supine position. We induce anesthesia in and of itself has an impact on FRC without giving muscle relaxation. Paralysis of the muscles to a significant degree will further. Look at all this compression on the lower lung units. The diaphragm is just way, way, way up in the chest, decreased FRC. And then again, this is surgical displacement. That's probably just from a minor impact. When we get into exaggerated lithotomy, when we get into exaggerated Trendelenburg position and pneumoperitoneum, I mean, the chest, when you're trying to ventilate these patients, you can imagine their diaphragm is like up at nipple line. It's what it feels like. It's not really, I don't have any evidence to say that, but simply recognizing that this is one of the fundamental issues. And of course, again, the thing here is we've taken the diaphragm's ability to move and manage respirations away. All right, so now we can understand that the pulmonary effects are overwhelming in a person who has no endotracheal tube, no mechanical ventilation, positive pressure ventilation. That would be overwhelming. We come in to save the day, We're going to put in an endotracheal tube. We will initiate positive pressure ventilation. We have to do that mindfully. Think about how we're doing that. We know that, again, we get something, we get the ability to ventilate them without a risk of aspiration, so forth, but we also give up something. Increased airway resistance. So we have to overcome the resistance of the endotracheal tube. Just some reminders here. This is important to know. Certainly, it is a significant increase in airway resistance by having to breathe through a straw versus breathing through no straw. Typically, again, some of the other things that have an impact on pulmonary function, I think these are more intuitive. I spend less time on them, but just something to think about. Hypothermia, dramatic position changes, fluid management strategies. We're spending a lot more time finding out what are we doing to these poor patients with all these crazy fluid management strategies that we're using. 6, 8, 10, 12 liters of fluid. Sending up in their lungs, that has an impact. Big fluid cases have an impact on the pulmonary function and the risk for postoperative pulmonary dysfunction. Certainly, we want to use positive pressure ventilation. I'm not advocating that you don't breathe for your patients, that you don't implement positive pressure ventilation, but you always have to think about the other side of the coin. These are familiar to you guys. Also remember, do no harm, folks. Carefully managed ventilatory strategies can help avoid harm, and sometimes we get aggressive with our ventilation. You'll look up, and you've put them on the vent, everything, the default settings. Don't do that. We're going to talk about this at length, but the default settings are often set for a person who is 6'4". Tidal volume is dosed on ideal body weight, so we need to know what the patient's height, what their ideal body weight is, and you need to dose your tidal volume accordingly, and many of the times your defaults on your vents are not set up that way. So you'll look up and your end-tidal CO2 is 24. That's badness, folks. So iatrogenic complications. We need to be very, very, very cautious about our ventilators. They do not have some of the safety mechanisms. They have some that are specifically attuned to the perioperative environment and some that we need to have better, and they're not present on every anesthesia machine that you'll work with. They don't have always safety mechanisms to prevent you when you release a pneumoperitoneum from giving, because your settings are one thing, and then they take out that pneumoperitoneum, and the ventilator has no mechanism to auto-adjust in some cases. So you were giving 450 tidal volume with the settings as they were with the pneumoperitoneum and Trendelenburg, and then they release that, and you've now got 2,500 of tidal volume. That can happen. So you have to think about, again, that iatrogenic complications. We do buy some things, the volatile anesthetics, which we use heavily as our maintenance drug. They do have bronchodilation properties, but we also have to think about there's other effects that they have as well. Clinical versus textbook is debatable in terms of the degree to which they inhibit HPV and so forth, but they certainly may have an impact on those homeostatic mechanisms, things that your body would normally do to offset the changes that it's sensing, we take away with volatile agents and the other drugs that we've given. The effect of bronchodilators on airway resistance, you can review that. This is a graphic, a very commonly cited graphic, which describes again, this is the CO2 response curve and the effect of volatile agents. You guys have all seen this before, just something to think about and to review. I just put up a new article on Blackboard. It's a supplementary article, but it talks to a large extent about HPV. I want you just to, this is not going to be stressed heavily in terms of testing on this particular lecture hour. I want to put HPV out there as something that you need to be thinking about because it's a heavily covered concept when we get to the thoracic anesthesia section. So just start to read a little bit about this and review. You guys have heard of HPV before? Hypoxic pulmonary vasoconstriction. Great. Some of the things that inhibit, not a ton of them specific to the perioperative environment, but inhaled anesthetics certainly can inhibit HPV. So that's something for us to think about in addition. Some of the other drugs that we may give, iatrogenic hypocapnia, that could be a problem because it upsets the body's ability to maintain homeostasis. You've missed this guy, haven't you? You've missed this guy. So left shift of the oxyhemoglobin dissociation curve associated with, again, hypothermia. We're going to make our patients cold. That has an impact on their oxygen carrying and oxygen delivery capacity. So just think about that. Again, over and over and over. Hypocapnia, alkalosis have other effects other than just the number's not what it should be. They have significant impacts on your patients. What is the biggest impact of all of this stuff that we will see? I've kind of touched on it a little bit. The required readings really do largely speak to this. Atelectasis. Do we more often have problems and difficulty oxygenating or difficulty ventilating? We've bought ourselves a lot of room on ventilation, right? What are the things that make it such that we're not able to ventilate patients? Patient ventilator asynchrony. Metabolic rate. We've just lowered their metabolic rate. It's cold. So, we're able to ventilate them. We don't often have trouble in the perioperative period because of those things. We've anesthetized them. We've taken their oxygen requirements down to very little. But if we were to have one of these two issues, which is the bigger issue, very likely? Probably oxygenation versus ventilation. We will certainly get into situations. What are some of the big ones where we might have a serious bit of trouble ventilating a person? I've already kind of mentioned it. 45-degree Trendelenburg with pneumoperitoneum and the legs in stirrups. You may have serious issues trying to ventilate them, but if we're to tackle a challenge first, it's strategies to improve oxygenation in the perioperative period, the ventilatory strategies in terms of trying to get ventilation in. But again, just some of the couple of things. Intraoperative issues that we've talked about that are most highly associated with postoperative pulmonary complications. I'm going to point this out. It's atelectasis. What percentage of patients under general anesthesia experience a significant degree of atelectasis? Anybody read ahead? That's the take-home point there. What percentage of patients under anesthesia? It's in your atelectasis article, and we'll leave on that and start talking a little bit about COPD. Emergence issues, of course. Again, now we've taken these up. Just highlighted some of these here. By and large, the focus here is on the pre and intraoperative phase. But again, I've mentioned already, I'm not advocating you don't use 100% FiO2, but it certainly contributes to atelectasis. And inadequate. We're going to talk a lot about neuromuscular blockers and inadequate reversal and so forth, but at any rate, that can certainly have an effect. All right, let's get on to COPD. All right. I've already mentioned the focus here, the single objective for this bit of time is that you're able to walk away from here and have some degree of certainty about what are the major things that you need to include in your anesthetic care plan for the patient who has COPD. Everybody has dealt with patients who have COPD in the past, yes? Everybody has dealt with patients who are mechanically ventilated in the past, yes. Anesthesia ventilators are a little bit different. We're going to dig into ventilatory strategies in its own hour. And we'll revisit some of those things, some of the features, what is different about an anesthesia ventilator versus those that you may have worked with. But some of the concepts that we're going to talk about today are really largely based on what you already know and the fact that you have some experience managing patients who have COPD. So we'll kind of start with that. Again, I'm going to highlight some things about the pathophysiology of COPD. This is not an hour about the pathophysiology of COPD. It's a good time to review that if you really haven't visited that for a while. If you're in a pediatric unit in the past, maybe you didn't deal with a lot of patients with COPD, it's a good time to visit that because some of these things really do underpin what we're going to talk about as far as the strategies to manage the patient with COPD. It is not uncommon. Thankfully, we don't see a terrible number of patients who have serious COPD. Why do we not see as many of those? Because we know that this is out there. It's a very common disorder. Poor patients aren't candidate for surgery a lot. Their risk factors are huge. This is a major, major determinant of whether or not some folks will get these surgeries done. That's just my own take. But I think there's a lot of patients out there with COPD who are deemed, we better not do that. They're teetering on the edge of not being able to maintain an oxygenation on a day-to-day basis. So the very severe patients with COPD. You guys recognize, again, that this is this really encompasses this large group of disorders. We have an entire lecture hour for asthma. So I'm going to try to tease that out of here, though certainly I recognize that as an obstructive disease, asthma falls into that category, but we're going to deal with that on its own, because particularly things like dealing with intraoperative bronchospasm. We'll talk about that later. But again, one of the fundamental characteristics with all of these disorders is a resistance to airflow, primarily with inspiration or expiration. Exhalation or expiration, airflow limitations. Again, this is not uncommon. Some of the most up-to-date statistics here, smoking is by far the largest risk factor for this. So now we have a care plan that is for the patient with severe COPD, and in many cases, some specific attention within that care plan for the fact that these patients are very often active smokers. How many have seen that patient out smoking through a trach site? Continuous oxygen, take your oxygen off and still smoke. It is a serious, serious addiction. I mean, this is something these folks are just simply unable to put down. They can't seem to do it. The prevalence of COPD, at least as of the latest statistics that I found, again, just laying the groundwork, it is not uncommon. There is a slightly higher incidence in males and white patients, and it does increase sharply with age, because this is something that is not a smoke 5 cigarettes or smoke the magic number of cigarettes and boom, you had 0 COPD and then you have severe COPD. This is a long progression of repeated damage and damage and damage and damage and damage. All right. This is an interesting thing to me. Less than 50% of the patients, if you did a pulmonary function test on all the patients that are walking around, 50% of those patients who meet criteria by PFT for COPD do not have a diagnosis. So there's a lot of folks walking around. Heavy smokers have a high suspicion that they may have some degree of COPD, even if it's technically, it was like the guy that comes in, it looks, I mean, oh my goodness, looks a mess. Ask them about their medical problems, and they say, oh, I haven't been to the doctor in years. Because we didn't know about problems doesn't mean I'm healthy. I didn't go to the doctor. It's not that they didn't go to the doctor because they were healthy. They didn't go to the doctor because they couldn't go to the doctor for some other reason. So just because they don't have that diagnosis in the letters on their chart, that doesn't mean that they don't have COPD, if you will. All right, our challenge becomes figuring out when we need to find out more. Again, just some highlights here. I'm just bringing out some of the highlights of the pathophysiology. What are the effects on the central airways? What are the effects on the peripheral airways? What happens over time? This is the lung parenchyma, an important thing. Again, loss of alveolar attachments, and you get peripheral airway collapse. Does this largely affect the earlier segments of the tracheobronchial tree or the distal segments of the tracheobronchial tree. Tends to be more affecting the distal airways. Some of the important things to think about as well is you might think that pulmonary vascular changes are a late finding. In fact, the recent thinking on this is that we can start to see changes in response to COPD very, very early. You don't necessarily progress to cor pulmonale and right heart failure early on, but if you look at the pulmonary vasculature of patients who have COPD relatively early in the natural progression of this disease, you will start to see some of these changes, and that certainly contributes to the compounding. The disease gets worse and worse and worse over time. Mucus hypersecretion, certainly you can see these things early. Again, kind of goes along with the fact that these folks are often smokers. You will start to see expiratory airflow limitations, and what does that mean? All of the volume that gets in the lung is not getting out of the lung, so we see this hyperinflation that goes on a chronic basis. Obstruction to exhalation on a chronic basis. If you see a person who has, again, this chronic hypoxic pulmonary vasoconstriction, they're trying to shut down the lung units that are not participating in gas exchange, cor pulmonale effects. If you see a person who has muscle wasting, you can see that in the patient when they come in to see you, right? You take one look at them. That's the doorway assessment. You see this little person who's having trouble breathing, maybe you know they do or they don't have COPD. These are typically diagnosed, but these are very, very, very late in the disease. You can already imagine the impacts of severe COPD on the patient who's having anesthesia. All right, we've talked a little bit about decreased elastic recoil. We've increased compliance in the small airways. The air goes into those areas. That's a key point. What did I talk about before? That in healthy patients, typically relatively homogeneous. So what happens in patients who have COPD? You can read it on the slide. They get very heterogeneous. So what happens to the positive pressure of ventilation that you put into these patients' lungs? Where does it go? If it goes to the path of least resistance, is it going to go to a more highly compliant or to a less compliant area? If they're going to go to a more highly compliant area, wait a minute, they already have enough airflow into those highly compliant lung areas, so it gets trapped in there, and we get preferential distribution of airflow with positive pressure ventilation into lung units that don't need more. So this heterogeneous compliance, that's a key point in this, and it's counterintuitive. It's a situation where we have increased compliance in those diseased lung units because they don't have that elastic recoil. So you can get air in just fine. Ventilatory strategies, getting air in them, not a problem. Getting air out of them, huge problem. This is staggering. What is the normal ratio of dead space to tidal volume? What percentage of our tidal volume is typically dead space, to put it in very layman's terms? Under 30%. In these patients, you may have, 10% of the inspired volume is actually participating in gas exchange. That's a problem. Not all patients with COPD are created equally. We used to talk about these as the blue bloaters and the pink puffers. If that helps you remember it, it's certainly fine. Certainly recognizing that some folks with COPD may have very copious secretions, others not so much. Patients, what's one of the key points on this slide? What is one of the key factors that becomes an impact for us in terms of patients with COPD? CO2 retainers versus non-CO2 retainers. We get so used to looking at our normal end-tidal CO2 numbers, we will iatrogenically cause harm to these patients because we're going for normal and they may or may not be normal. So in a very severe COPD patient, this becomes a key factor. Not to know, this is a chronic bronchitis patient, this is a chronic emphysema. I mean, certainly, again, there are differences in recognizing someone who has emphysema may be more at risk for certain issues. Someone who has bronchitis may be more at risk for others. Is that to say that no patient with emphysema has ever retained CO2? No, what is typically the presentation? They got some degree of this and they got some degree of that. Some people retain CO2, even though on objective findings you wouldn't expect them to do that. So, knowing whether that person individually is a CO2 retainer or not, what is their normal PaCO2, that would become an important factor. If we had to categorize these patients into camps, these are how they'd probably fall out, but is that necessarily hard and fast? No. It's a mixed pattern. We're trying to put things into boxes that don't necessarily go in them. It's not necessarily amenable to that. So that's one of the key points here. Again, if we had to guess, and certainly that does not mean, folks, that these are not testable material. Please don't think that this is stuff you don't have to know for the test. We do for tests what? Try to put things in boxes. So we'll phrase it in such a way as, if a person was CO2, more likely they'd present a picture of chronic bronchitis and would have other factors that kind of go along with that. So certainly review this, kind of pay attention to that. But clinically, I will absolutely acknowledge that people don't necessarily sit in a box or another box with no foot into the other side. All right, what are the characteristic changes that we will see? Again, if you don't know the normal lung volumes, then it's difficult to really understand what exactly happens in COPD. So this is important to recognize, and I've really highlighted the key ones here. These are not the only ones, but you can certainly see here which of these is the normal pattern. Yes, this is a normal patient. This is a COPD patient, and these things are largely represented here. Increased total lung capacity. This total lung capacity is smaller than the COPD patient, so the COPD patient has increased total lung capacity. Increased residual volume. So look at this. Here's our FRC, and the normal healthy person, this much is residual volume, and this much over here is what? What is ERV? Expiratory reserve volume. That ratio changes, and predominantly because we have this increase in residual volume. The amount of volume in the lung that we can't get out is increased in a patient with COPD. What's decreased? Forced expiratory volume in 1 second. They also have other pulmonary function test parameters that are decreased. These are the primary ones, the ones that we're really going to focus to a large extent. The FEV 2575 is a big one, but we're going to focus predominantly on this one, the forced expiratory volume in 1 second. If they can get it out at all, it takes a lot longer to do that. Vital capacity, again, because they can't get it out, that's measuring how much volume they can get out of the lungs. And the ratio of FEV1 to forced vital capacity. What is the normal ratio for FEV1 to forced vital capacity? 0.7 or 70%-ish is the cut point in a lot of situations for normal and not. And in patients with COPD, we will see, in some cases, a dramatic decrease in the ratio of FEV1 to forced vital capacity. And we're going to talk about what are the cut points for that. How low does it go? That is a major impact in terms of how serious and how aggressive does our care plan need to be in terms of managing these problems associated with COPD. That depends largely on their FEV1 to FVC ratio. I don't know why it's not erasing. Okay. How many of you have seen this loop before? Yes? It's really helpful to revisit this. I know that you guys are familiar with this. Look at the parameters on here. Flow rate per second. That's really important to note. What is the peak expiratory flow in this patient? Well, first thing, it's important to remember that the top of the graph is exhalation and the bottom is inspiration, yes? That's really important to keep in mind because they'll change these all over you. So when you look at a graph, make sure you know which is which on that graph and which direction we're going. So if we're looking at exhalation, we're on the top. What is the peak expiratory flow rate in liters per second? Around 7 liters per second. Up here, which way does exhalation go? We're measuring exhaled volumes on this bottom, and notice that the numbers switch. How much volume is exhaled? They're measuring that here. That's how fast it gets at the fastest, and then how much exhaled volume here, amount of exhaled volume has to, but at this point we're sitting with how much volume in the lungs. You got to look at the bottom axis to know that. And then we exhale. We're just measuring from 0 exhaled volume at the end of inspiration, pause, then how much are we exhaling out. So that's an important thing to think about. So that's not the lung volume at which we're sitting when we start exhalation. That is, how much am I measuring from that pause between inspiration and exhalation. So keep that in mind as you're looking at this. So peak expiratory flow rate, and then where's the FEV1 in a healthy person? FEV1, maybe way down there. In 1 second, they can get out a lot of that. I want you to notice something here, guys. What does this look like here? We hit peak expiratory flow early, and we have this nice steady decrease. We're going to see a change in that limb of this curve in a patient with COPD. See a very big change in that limb. So that's one of the points to note. So FEV1 noted on here. This is on PFTs, guys. This is not normal breathing. This is abnormal breathing. How many have done a PFT, have had one done on them before? That's what my husband is doing full time these days. The new change over the break. That is a really, really, really informative thing to go through. I've had to do these tests. You get a much better, like the light bulb just went on. Like, we've been talking about PFTs for a long time, and I didn't know that. And it's not very comfortable to do this. I mean, it's really, more difficult to participate. Like, we see those PFTs that come back and they're poor effort. You can imagine, I'm a young, healthy person. I do the test, I go, whoa, give me another try, I gotta do it again. And I do it again and get the full effort. So it's more difficult than you think. These are unideal situations here, but at normal tidal volume, look at how little of our lung capacity we normally use during normal tidal breathing. We don't need as much. We have a great capacity to increase that under stress and other reasons. So again, peak inspiratory flow rate here, peak expiratory flow rate up there. Some of the key points that we'll see are a change in the FEV1, less measured volume. So what does that mean in terms of your FEV1 if you were to march it out on this curve? If we're measuring from 0 exhaled volume here to FEV1 sometime over here, whatever 1 second takes them to do, it's going to be less volume exhaled in 1 second, right? So that curve is going to get squeezed in. And that's what that means, is they're able to get less volume out in that second. So it's going to be a more narrow curve. If you're looking at the width of it from here to here, FEV1, again, it's going to fall somewhere on there. How much, 1 second, how much volume did they exhale? That curve will be squatted in. And then if you look on the bottom, I really love this particular graphic. On the very bottom of it, it marches out the lung volumes and capacities on the bottom of that screen. So that last picture is really nice. I'm going to keep moving on. This is just looking at the idea that expiratory flows are effort dependent. This one takes you a little bit of time to march through. I'm putting it here because I just want you to kind of think about this, but certainly not something we're going to spend a lot of time on. We just talked about this one. What are the big things that you notice on the two different curves? Peak expiratory flow rates are significantly decreased. And look at this. Overall lung volume exhaled decreased. So that scrunches it in. We're looking at the entire exhalation. And then again, it doesn't really tell us here where the FEV1 is, but the forced expiratory volume in 1 second is decreased. And then look at this. The peak flow rate, you'll see this in some curves is much more exaggerated. You'll see that peak expiratory flow drops down in some of these curves. So if you're looking at this curve, the contour of that curve looks very different. They're not able to maintain quite so high of a flow rate. This one does here. Key things to know about that. Again, I mentioned that FEV1, forced vital capacity, would be one of the discriminating factors between whether or not a person has COPD at all, and then certainly we're trying to grade it out and trying to determine how serious is this person's COPD. That's one of the parameters primarily that we will use. And one of the things that you notice is this is post-bronchodilator. So we're going to give them bronchodilators during the test, and it's always the post-bronchodilator FEV1 to FVC that we will look at to determine whether or not this person has COPD. What are the predicted values? What are they normalized for? Would mine be different than yours? Wait, is anybody else 45 in here? You? Over 40? Ah. All right, because nobody else as old as me in the class. All right, male to female makes a difference. Certainly, they enter in all the parameters. What are the parameters that they enter into here? They will enter in your demographics, your age, your sex, your height and weight, so forth. So they enter all of those into this normalized value. You do see some discrepancy, some controversy in literature in terms of, well, that predicted value really isn't what it should be. With normal healthy lungs, I can tell you a lot of my values, FEV1, FVC, et cetera, were higher than predicted. It's like, woo woo, use those lower values. So I think they're fairly reasonable. That's my assessment. I mean, I don't have any lung disease, but at any rate, the predicted values are sometimes controversial. So you may occasionally look at the actual value of that, but usually we trust that the predicted values are somewhere in the range of where that person should be. So it's percent of predicted. You need to think about that if you're looking at a PFT in terms of the actual values that they look at versus the final report. They'll give you this final assessment. We may want more than that. The machine, like an EKG machine, you guys know that. When you do a 12-lead EKG on a person, this is not your assessment. This is not the cardiologist assessments. The machine itself will spit out some numbers and tell you this person meets criteria for X, Y, and Z. And they're often right, but not necessarily. And likewise, you have certainly an interpretation of that by an expert in pulmonology. So hopefully you agree with their assessment, but we may want more information than that. So we may want PFTs, and we may also want to know specifically what these parameters are. This is the one that I might look for on the PFT readout. And again, what are the cut points here? COPD period is post-bronchodilator, FEV1, FVC, and then as far as the severity, we're looking at the FEV1 percent predicted. So here's the cut points. And some of them, again, will be 80% or greater. You'll see 80, you'll see 70. We're using 70%, less than 0.7 FEV1 FVC ratio. And what are these? These are different, right? That's what I think some of the confusion is. Some folks will use as a marker of abnormal lung function FEV1 FVC ratio less than 0.8. But some of that may be getting confused with this one over here, which is percent of predicted. Do you see the nuance there? So the ratio is different than percent predicted. You need to make sure that you're looking at and using the parameter that is the one you think you're looking at. It's basically the bottom line. So this is this a volume or a flow rate for FEV1? What are the units for the values? Let's not look at this. Let's look at FEV1 predicted values. What is the number going to look at? They're going to show us what? What units? Liters or milliliters. So that's a forced expiratory volume. The person's measured volume, my measured volume, versus what they would predict for a 40-whatever-year-old woman of my height, weight, etc. So percent of the predicted value. I would predict that a person with normal healthy lungs would have an FEV1 of whatever reference value it is, and then what percentage of that predicted value is I. So that's where I think there gets some confusion. Some sources will use a ratio of FEV1 FVC as less than 8 for abnormal, 0.8, 80% abnormal, and then COPD diagnosis at less than 0.7. But for the most part, we're sticking with these FEV1 FVC ratios of under 0.7, and I think that's where the confusion gets, is in noting whether or not it's the ratio, which has really no units. You're looking at a percentage of FEV1 to FVC, volume over volume, so there's no units there, versus the FEV1 percent of the predicted value, no units, but it's different things. Okay, so COPD. Who are the patients we really need to worry about? Clinically, what am I worried about? We're really probably very worried when we start to get into this severe and very severe COPD. If your FEV1 is 50% or less of the predicted value, that is a big, 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 big deal. And I'll bring that up on the next slide. All right, jumping into the care plan. What are the patients going to come to? And this is not information that I want you to go through and recognize all of the new inhalers that are out there. You don't have to go through and memorize. Those are not drugs on the cart except for one. What one bronchodilator is on the cart, inhaled anyway, that you need to know about? Albuterol. Short-acting bronchodilators inhaled we will often use on the day of surgery as our rescue. We have few choices in terms of inhaled agents. The one that we most often use is albuterol, so you do need to know about that one. This information is here because you need to recognize we have a lot of new drugs that are out there. I do not expect you to be an expert on all of the medical regimen that patients who have COPD would come to you on, but just recognizing when they are on certain classes of drugs, why would they be on those? And then look, if we can look those things up, what are some of the implications of some of these other drugs? Knowing whether they're on short-acting or long-acting, how often do they need, those kind of bigger picture issues. We're seeing fewer and fewer patients on methylxanthines, but if your patient comes to you and they're on an inhaled anticholinergic, you might want to know about that, those sorts of things. Another big thing to know, certainly, would a person who's on 2 or 3 different inhaled steroids need to be covered for steroid prophylaxis, risk of adrenal insufficiency during the perioperative period? Any steroid, inhaled. How about Abingdon? Inhaled steroids. Severe COPD patient comes into a multiple drugs, a couple of them are inhaled steroids, they're on max doses of those. Would we be concerned about adrenal insufficiency in a patient on inhaled steroids only?
I would say yes. Or no.
All right, Brittany, I'm going to pick on you.
Okay. Can you hear us? Can you not hear us?
I do. You're not off the hook?
He answered, and so I didn't know. Well, you can pick on Brittany, though. That's fine.
What's that?
I'm going to say yes.
Maybe.
Largely no. But what's the issue with those folks? If they're on max doses of steroids, it's more of an indirect marker of somebody who has very likely at some point in the last 6 to 12 months. So I worry about them, and yes, they may end up getting coverage, but purely based on the fact that they were on inhaled steroids, no. And then if they've had any other steroids, systemic steroids of any sort, and COPD patients frequently do end up on steroids at some point. Again, some of the other things, it is really key that we know whether or not they're on oxygen at home. It is really key if they're on oxygen to know what their baseline oxygen saturation is and what their regimen is. Some patients will use oxygen only at night. Some patients will need it 24/7. Just need to know that. They come to us with a smoking history. They also have, this is just looking at the anesthetic implications. One of your jobs this semester is to do a care plan. If you encounter a patient with COPD early in your clinical career, bump out that care plan and start to work. And this is a lot of the information. This is what I want you to be thinking about when you're making your care plans. Patients with significant COPD are good patients to do your care plan on. So if you run into one of those, great. Dig in, do your care plan for this semester, get it over with. And here's some of the information that you're going to need to think about. Varies depending on the patient and the severity in their particular situation, but some of the things you need to think about that they have an increased risk of intraoperative hypoxemia. Certainly they are at risk of mucus plugging in some situations. Not all patients who have COPD are mucus makers, but many of them are. They may be at increased risk of bronchospasm, and they may have underlying cardiovascular dysfunction. They have extra workload on their right heart chronically. So we'll look for those changes, evidence of those things. What's going to tell us about a person who has evidence of right heart, right ventricular hypertrophy, right heart issues, core component. What are some of the things that we look for? Clinical signs and symptoms. You guys know these things. We're pulling all this together. So clinical signs and symptoms of that, JVD, increased right heart pressures, etc. We may look for EKG changes. What EKG change might you see associated with that? Great review for you guys. Peek at that. You may see some of these EKG changes. All right, they are also at risk of increased postoperative pulmonary complications. In the patient with significant COPD, look at this. Let's go ballpark. 3 to 5 times the risk of postoperative pulmonary complications compared to the young, healthy person, irrespective of other risk factors which may be added on and added on and added on and added on and added on. So if they're having thoracic surgery and they have COPD, their risk for postoperative pulmonary complications is dramatically increased. What specific things? Persistent and profound arterial hypoxemia, hypercarbia, and certainly infection are some of the big ones that we think about. Not so much the atelectasis, as we were talking about with a lot of the other patients, right? Because they can get air in, just can't get it out. We need to really get an extent of, we've talked about what are some of the questions and follow-up that you would ask this person. It comes down to a case-by-case situation and assessment of what their baseline status is. It is absolutely vital to know whether or not, okay, relative to how they live, because it's going to look crummy, right? COPD patients look crummy at baseline, in the best of scenario for them. What our trick is to figure out, is this as good as they get? And if it isn't, what's going on? If there's some acute issue going on, what are we going to do? This is a complex disorder, folks. We're going to refer them to pulmonology, right? Maybe we decide that they're that factor plus surgical factors, duration of surgery, big fluid shift, we start to add all these other things. At the very least, we need to be having these very informed conversations with these patients. I'll talk to that in just a little bit, but we also need to think about whether or not that patient is as good as they can get. Some of the factors that you need to think about I've listed here. We want to interview the patient at length. Your interview goes wherever we need to go for that person. What are their symptoms? What is good for them? What is it? Do they have shortness of breath at baseline? Are they always short of breath? What is their exercise tolerance? How much can they increase their activity and still keep their breath? These are really important things for us to know that will help us get a good idea. Looking at the EKG, assessing for changes, right heart failure changes, chest x-ray, not as significantly helpful as you might expect. One situation where it does really help us a lot is to determine whether or not this person may be at risk for having blebs. And we'll talk about why that's important in just a second. For this emphysematous patients who may have blebs, they're at increased risk of problems perioperatively specific to that. And then, of course, their baseline pulse ox. This is not the person to skip the pulse oximetry check. Where do they live? That's where we're going to try to get them. Our parameters for oxygenation during the perioperative period are typically where? Minimum of 94 is kind of along the lines of ACLS, etc. I like to go for better. I really like 100%. We do titrate our oxygen and other ventilatory parameters to try to achieve, a reasonable baseline, but we need to know what that is. Smoking cessation is a big issue. Certainly, we're one of many people who can impress upon them smoking is a bad idea, particularly throughout the perioperative period for big surgeries, but that may or may not be something that has a place. We've talked about steroids. Do we discontinue specifically any COPD medications? No. Keep their medications going. Hydration may be a key factor for them if they have very dry secretions. And chest PT or incentive spirometry preoperatively. Kind of like a pre-op pulmonary rehab may be in order for these patients. All right. Discuss the potential for postoperative mechanical ventilation for high-risk procedures, kind of speaking to this informed consent. We really need to have a good conversation with them based on where you are, where we will, what is the risk? They want to know how likely is it I'm going to stay on a vent afterwards. And what is the situation for some of these folks? That's not worth it to them. Because I cannot guarantee they'll be off the vent in 24 hours. They need to know that. Not otherwise giving them the best information. Regional versus general is a discussion largely for this summer. You need to know more about regional anesthesia before we can really get into that. But in and of itself is not a definite, they're not going to have any impact from that. There are simply many implications of regional anesthesia that you don't think about. So that can be a factor as well. Whether or not to put monitors in, we don't really have a lot of other respiratory monitors that we can put in. I'll talk about a couple of them here, but for the most part, there's not other respiratory monitors that we can add to the mix. You may want to have that COPD patient in another room so that you can get to the ventilatory. You can use the vent strategies that I'll describe to you. I'm going to describe those under ventilatory strategies. I've put them here because you have to have them sort of in line with this. We're going to talk about vent strategies. We haven't talked about basic vent stuff. I can't really largely talk about this here. There are certain anesthesia ventilators that can do the things we need them to do for patients with COPD, predominantly the monitoring component, not as necessarily the functional component, but in a patient who's very severe, that would be advantageous to have a machine that can give you the graphics and the other information that you might want to have to help figure out what's going on with them. Determining whether or not they have auto PEEP. It's easier if you have graphic packages. So that's my take on that. Some key points to think about as far as the COPD patient. I'm coming to the end of my time. Do we have to have the head of bed all the way flat? If they're short of breath that way, not necessarily. We can overcome that. We need to think about moving them for them if they can't really get up and move around a lot. If reserve is low, why waste their reserve and get them short of breath and they go to sleep dyspneic because we made them move themselves? And then there is a potential for hemodynamic instability. That's really reserved for those patients who are very, 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 very severe. General things that I'm going to talk about, again, I've put them here. We are not going to talk a lot about vent management today because we're going to talk about basic ventilatory management in its own hour. So these are some of the general things. We're going to talk a lot about this. Before next week, here's one thing I want you to think about. What is IE ratio? What is a decrease in IE ratio? And what is an increase in IE ratio? Food for thought for next week. And I've got some graphics and videos here that will help you start to make sense of some of the graphics that I've talked about. They may be at risk for reactive airways, and we're going to let Dr. Cook discuss that. When we start talking about the graphics packages, there are ways to determine whether or not this person has reacted well to the intervention that you may have implemented. I don't think Dr. Cook talks about that, so we'll have a little bit of discussion about that. Do we extubate the person with COPD or not? Are they a candidate for extubation? I try to extubate everybody. Our goal should be extubate everybody. But there are situations where a bridge, we're using a ton of BiPAP. COPD patients have probably seen that before. Why risk getting them into a badness situation unless you have bridge, unless you have to? Why? I can extubate them. Do I get a star on my report card? Yay! No T pieces for me. I take my patients all to PACU with no endotracheal tube in. Guys, there's no star on your report card. You're going to do what's best for the patient. It is not a failure, particularly in a patient with this history, to take them to the PACU intubated. So take them to the PACU intubated and consider bridge therapy if you need it. What's the key point about this? Anybody seen the Transport Fancy anesthesia BiPAP machine? Not seen that? It's because it doesn't exist. There isn't one. Call respiratory therapy. You have to have that set up. You have to call 15, 30 minutes in advance. If you think you might potentially need that, there you go. If you need an idea for your $1 million to be made, my contribution. Post-operative care, you guys know this. This is what you've been doing. You guys know all of those factors. All right, ventilatory strategies, IOU. The rest of it we have on the slides here. Again, we have additional time outside of class. We can talk about some of this stuff. It really depends on the patient's presentation. It's a bottom line, but some things to think about. You can largely march through a care plan with this information, and then we can customize it to the severity of your patient. Questions? Rotten tomatoes. Who wants to go home? All right. This is a slow play. We're easing on into the day today. We're going to ramp it up as we go on throughout the semester. I'm sorry I didn't give you the full 10 today. I'm working hard. I'll get there. We didn't go over 10 o'clock. So you get 5 minutes of break. Thank you guys very much for your attention. I will see you guys tomorrow probably.
Hey, Dr. D'Amico, Northern Virginia has a quick question. For the quizzes, they're going to be open note, obviously.
Okay, say it one more time. Talk a little louder. Your speaker's low.
I'm sorry. So for the quizzes, they're going to be open notes. But for the last semester, we weren't able to open up our notes online, like on our computers while we were taking the quiz.
That's not true this semester.
Okay, perfect.
Yeah, these are going to be set up as non-secure. So I depend on you guys not to screenshot them, but the out-of-class soft test quizzes for this semester are open, like non-secure. So it is not a lockdown browser situation. You will be able to open the quiz, access it, and access other files on your computer.
Wonderful. Thank you.
Thank you for pointing that out. See you soon, guys.
I have a question. I think I missed it. So patients are like 70, so do they need higher PEEP because they have more like atelectasis?
If they are,
Or do they need more PEEP setting?
yes, we're going to talk about recruitment maneuvers. We're going to talk about
That's what
setting
we're
your
talking
PEEP
about.
value. Absolutely. So
Okay.
those are really the two big things. Periodic size, recruitment maneuvers periodically. In addition, inventory pauses, PEEP value. I'm going to preach to you. We need to be having all patients on. How many patients have atelectasis in the perioperative period? All of them. And if they're at particular risk for that, then we're going to need to do really aggressive measures to prevent that. But yeah, that's ventilatory strategies.
On the EKG changes, is it just the tall peaked P waves and lead to signaling? Or is
It's
it
the biggest one, the quickest one you can see. Yeah, atrial hypertrophy.
that one could be mitral, right? The left side. Elevated. And then of course what else is it? Long-standing right heart failure. Other than the peaked P waves, or other than the P wave
Somebody's phone?
Mine.
Okay.
Trying to give it away all day
Oh,
today.
I didn't even see
It's mine. I've
Okay.
been trying to give it away.
Yeah, sure.
Do you write on the computer very much?
Yes, I do.
Okay, it's
Yes.
a little slow today in
Oh,
getting
I
rid
see.
of
Okay,
it, so it'll
yeah.
hang up a little bit. I'll erase it.
Yeah.
It writes quickly, but then sometimes it won't go away. So I just
Oh, I
have
see.
to
Okay.
watch it. So it did work. Finally, I didn't have to restart it or anything,
Okay.
but just to let you know.
Sure, okay. And I was asking for Jerry, and they told me, oh my
Yeah,
goodness.
so you
oh.
need to meet a couple of folks. I'll bring them in to see you. We have a couple of other folks that are helping out
Sure.
while he's gone, but
Yeah.
he's just now getting to rehab,
Oh
so
my goodness.
it will be a while, if at all. I hope he's coming back. But.
Yes, I'm guessing we didn't call up with the bad news.
Yeah.
You can do webcast